Academy, Mangalore, and has joined Pallium India after serving in District Hospital Kollam and UST Global Medical Wing. She has been associated with Pallium India since last 2 years. So welcome, ma'am. Welcome to the session. Over to you.
Thank you, Sister Snehalada. So, good afternoon, everyone. Happy to meet you all. So, today we'll be dealing with the respiratory symptoms, the common respiratory symptoms we come across in palliative care. Okay. So, shall we start?
Ma'am, the slides are visible.
Okay. So, about the common respiratory symptoms in palliative care. So, I'll be discussing with you a few topics and a few things regarding breathlessness and cough. So, first is breathlessness. Talking about the prevalence of breathlessness, the usual cases we see here in palliative care, it will be mostly lung cancers. 75% it will be lung cancers, followed by COPD, chronic obstructive pulmonary disease, advanced cancer with metastasis to lungs, AIDS causing infections, recurrent infection, heart diseases, heart failure, patients having cardiac failure, renal disease, all this comes under we deal here. Those breathlessness, all these patients, they will be going to different doctors, they'll be getting different treatment, and finally, most of the time their symptom will not be controlled, and they come here for our care. So, about breathlessness, it is one of the distressing symptoms we usually see here because it causes psychosocial distress for patient and their family. Can you imagine your loved ones gasping for air? Hmm? It is very, very difficult even for the family to see their loved ones having all these kinds of difficulties. So it is causing so much distress for the patient and also for the family who are caring them. And it is also difficult for professionals like us, for sisters and doctors to handle the thing. It is because it is not like other symptoms. For example, for pain, if we give an analgesic, the pain will come down. And for some patients, the pain can become even zero. But that is not in the case of a patient having breathlessness. We cannot completely make the patient feel breathe easy. We cannot do that. Or if it happens, that is also very rare. What we can do is we can just reduce their distress or we can just relieve their symptom. So it is one of the distressing symptoms for both patient and the family who is watching them and for even us. So we have to learn about it, how to handle it. So how does a patient describe it? It's not like a breathing difficulty. It's not like sir, ma'am, I'm having a dyspnea. It's like different people express their feeling in different ways. So some people will tell like air hunger. What is that? Doctor, I cannot get enough air. My breaths don't satisfy me. I'm starving for air. Some people tell like this. For some others, it will be like work or effort. They'll tell that it's an effort to breathe. My breathing requires more work. They have to strain a lot to get a little air. Some people, it will be like that. And for some, what they'll tell is, they'll tell it as tightness, chest tightness. Something is tied around my chest and I cannot take a full breath. So these are the different, what the patient says. Okay. Now we'll come to the causes. We need to know the causes little more clearly, like to know more about the breathlessness. In primary diseases, like patients having malignancy, who are having a primary malignancy or having a metastatic lung malignancy, the tumor, sometimes it will be very small, sometimes it will be very large. Those tumors will be, which are very big. And what they'll do is, they'll sit in the lungs and they will obstruct the airways, the lung pathways and all, where the air entry is restricted and the patient will have like breathing difficulty. Others will be because of the lymphatic infiltration by the tumor. The lymphatic fluid accumulation will be there, and the patient can have breathlessness. Malignant pleural effusion, all these disease, lung malignancy can cause a pleural effusion, a massive pleural effusion, and the patient can have breathlessness. And as I explained before, the tracheobronchial obstruction, the big tumors obstructing the big airways and can cause breathing difficulty. Then comes the treatment, surgery, radiation, chemotherapy. All these can cause lung fibrosis, and this can even cause breathlessness. Now, about the other causes in cancer causing breathlessness, it could be ascites. What happens? How will ascites cause breathlessness? Can anyone tell? How can ascites? How can a patient with ascites who is having like a very big belly, having so much fluid inside, can cause breathlessness? Can anyone tell? No answers are coming. I want an interactive session. I'll ask and you can talk and you can talk freely. Okay. So
Jagrati is telling fluid pushes diaphragm,
yeah,
and Sonal is also telling pressure on the diaphragm.
yeah. Yeah, that's correct. When the fluid pushes a diaphragm and it will restrict the lung movements and the patient can have a big distress. Patient might not be telling usually patients with ascites come here. So they will not tell like I'm having breathing difficulty, but this patient they'll tell they have a distress. But when we closely watch, we can understand that this fluid might be pushing the diaphragm and the patient will be having respiratory distress. Then cachexia, causing respiratory muscle weakness. Proper inspiration and expiration will not be happening. And next one is cancer microembolia in the lung. This is very rare, but still they can also cause breathing difficulty. Then comes pleural effusion. These all are very common causes of cancer causing breathlessness. Okay. Now, other cardiac cause. It is not only cancer. Palliative care not only concentrates on, not only means it's not fully concentrated to cancer. Other diseases like cardiac disease, patients having cardiac failure, who is having pulmonary edema, who has tried all medicines, and in spite of that, also there will be not. There will be no symptom relief. For example, a patient having cardiac failure, patients having angina, patients having arrhythmia, myocardial infarction, who are having um, pulmonary edema and all will be having breathlessness. So we should not keep them away. This doesn't comes under palliative care. It's not like that. We have to include everyone. Okay. Now, those having pulmonary causes of breathlessness like infection. It's not like a small infection or acute infection, a chronic infection. COPD, patients having pneumothorax, pleural effusion, pulmonary embolisms. In all these cases, the patients they'll be going to a physician, they'll be going to different doctors, but still sometimes their distress will not be reducing. Hmm? So in such patients, we can see them. Now, another very important thing, anxiety. Anxiety is also a very important cause to have breathlessness. It is not just one cause of breathlessness. It is usually accompanied when a patient having breathlessness develops a breathing difficulty. Okay. When a patient having a disease develops breathlessness, when it is combined with anxiety, the level of breathlessness itself increase. There is a cycle. Hmm? We have to be very thorough with this cycle. This is very important. So the cycle tells that a patient having dyspnea will be always having a fear of dying. When a patient comes to your OP, and he is having a breathlessness, and later when we have settled, we have tried to reduce his symptom and all, and then after some time we'll ask them, what was in your mind when you had breathlessness? And most of the time, people will be telling that I thought I'll die now. So, when a patient has a breathlessness, the first thing that will come to their mind is they are gasping for air and they will die, which in turn increases the anxiety. Fear of dying increases anxiety, that again increases the dyspnea. So this is very important. You have to keep always this in mind. A patient having dyspnea will have all these fear of dying, and that causes anxiety, and that may elevate his breathlessness. Okay, so I'm not talking too much about this. This comes in the management part. So you have to keep this in your mind. Okay, when I tell about that later. So, so this is also a very important cause. Do not forget this anxiety. Next, now we have understood all the causes and where who can get treated, who wants treatment, and what are the other causes. How can malignancies cause? But we have studied everything. Now we are going to assessment. We are going to see the patient. We take a detailed history and we do a physical examination. And in the history, we'll include everything like we do usually. Onset, when did it begin? What is the duration? How frequently does it occur? Or is there anything? It's same like the pain, like how we assess the pain. We take a detailed history of the symptom. Then quality, how can she the feeling like we have said before, is it a air hunger, whatever. Related symptoms, a patient might be having associated cough, anxiety, isolation is and then about the severity. Out of a scale of 10, we'll ask them to tell like what is the scale of your difficulty, and is there any treatment taken. For some patient they'll tell like I've been taking a inhaler since a very long time, I have little relief with it. That is all very important. So we have to take a detailed history. Now coming to physical examination, we take a detailed examination. We check the vitals. We check the respiratory rate. We'll count the respiratory rate, seeing the chest movements for so for 60 seconds. We record the respiratory rate. Now, now the next one, saturation and pulse oximeter. In a usual setting, in a casualty, for example, a patient comes with breathlessness. What will the sisters do? The first thing, they'll run for a pulse oximeter. Is it not? Yes, we have to check the oxygen level. We have to start the oxygen. So we have to check the saturation. But there is something different here. Most of the time, for our patients who are having palliative care, for a patient having lung malignancy, the patient will be having a big tumor in the lungs and it will be obstructing the lungs, airways, and the patient will have breathlessness. But it could not be because of the hypoxia. If we give oxygen also, sometimes saturation might improve from 74 to 81, but the patient is still having breathlessness. Is there any use with the oxygen? Yes, that needs to be talked. I'll talk about it later. But this saturation and pulse oximeter, we don't want it here. Yes, we need it. We need to check it. But there is no point in keep on checking the oxygen level for some patients. Hmm? If we are sisters, if we have doctors or relatives in our family, and if you connect a pulse oximeter, and everybody will be into that. Oh, what is the saturation level? Oh, it is 68, it is 71, it is 72, it is 86. Ah, now it is improving. Is there any use? Sometimes there will not be. I'll tell it about later. So like every setting, we have to check the saturation level, but we should not forget the patient. The problem about the saturation and pulse oximeter is we'll be concentrating fully upon the saturation level when a patient with breathlessness come. That should not happen. You have to keep this in mind. I'll tell about this. So keep this in mind. Now we look for the general physical examination. We look for cyanosis. What is cyanosis? A bluish tinge in the tongue and oral mucous membrane when patient is having hypoxia and all. And now we go for a physical examination. We'll examine the patient whether he's having any. So most of the time, these patients with breathlessness, they'll be in a propped up position, and sometimes they'll be lying down also. So we have to position the patient. If the patient is having breathlessness, we'll talk about it later. But still, physically, most of the patients will be in a propped up position. They'll be active accessory muscle involvement, nasal flaring, mouth breathing. I'll show the pictures. Um, Propped up position means patient will be in semi-Fowler's position, and active accessory muscles. In patients having cancer cachexia, there will be wasting of this intercostal and accessory muscles of respiration. So that will be seen. And nasal flaring can also be noticed. These all things are not very important, but just you all to identify. Whenever you see this, you should understand that the patient is having breathlessness since a very long time. Hmm? So now we have assessed the patient. We have taken a detailed history. We have examined. Now coming, we are starting a treatment. Okay. Though, so in a usual setting, in a in a normal hospital, what things first come to your mind is the doctor will be coming and telling that, yeah, this patient is having breathlessness. We need to take an X-ray. We need to take a CT. We are suspecting this, that. But here in palliative care, we have to think twice. Twice means twice before you before you suggest a investigation, because most of the patients, they'll be in their end stage. The disease will be advanced. They'll be already having a lot of problems and nothing could not have been done. In such cases, in such patients, you have to think twice before advising before telling an investigation. If it is going to alter the line of management, if it is something help, you're suspecting something, then you can do it. It's not like you should not do any investigation for such patients. Not like that. But always think twice before saying an X-ray, before saying for the do a USG and come and everything. You have to think twice. If it is not going to alter the line of management, it is a waste. You should not do it. Okay. Now coming to the management. So before that, I want a participation. I'm just telling a case and I want to know how the in a normal setting this happens. A patient named X came to your OP with severe breathlessness, and he's having advanced disease. No treatment possible again. He is accompanied by his family who is very anxious about his condition. What will you do? And what happens in a regular setting? I want you all to speak. Unmute your mics and just speak. What things happen? It's not about the palliative care. It's about what happens in a usual hospital. Tell me what happens.
We'll check oxygen saturation.
Yeah. Then the patient is having advanced disease. He's having severe breathlessness.
We'll administer oxygenation.
Yeah. Okay. Then we'll give injections. Will you give injections?
Yes, ma'am.
Yes. Yeah, we give injections. We give nebulizations. We administer everything. And the patient can what will you tell the patient's bystander or caregiver, the family who has accompanied him? What will you tell him? You are a sister or you are a doctor. What will you tell? What will you tell about the condition of the patient? You'll tell
Ma'am,
that his
first,
condition is very serious. Yes, sir.
yes, ma'am. Firstly, we'll check the
Yeah.
perception of patient's attendee, that how much they know about this advanced disease. Then we'll, after knowing their perception, then we'll tell them the real condition which is there, and also we'll empathize them.
Yeah. Yeah. Okay. Okay. Okay, thank you, Jagrati. So, yeah, we'll tell about this. We'll see everything. We'll tell them that the patient's condition is very serious, and sometimes we'll tell that, oh, we can't keep here him in the wards. We can't keep here. We have to take him into the ICU. Will you tell that? A patient having advanced disease with severe breathlessness, will someone manage him in the wards? Most of the time it will be a no. Most of the hospital they will suggest an ICU admission for what? Better care. But the patient is having advanced disease. Nothing can be done. The doctor also knows, the family also knows. Is there any pointing in taking away the patient from his family? Yes. From there you have to think. We are going to think differently from the normal setup. We have to think. he is in his last days of life. He's with his family. He's tensed. He's breathless. He has all the fears of dying. Everything is there. And you are telling that your condition is serious and cannot keep him watch, and you're taking to ICU. Will you do that? No. First, we have to communicate. We have to communicate with them. In this situation, we have to address both patient and the caregiver. As we said this before, psychological support has to be given both to the patient and to the caregiver. To the patient, empathy is very important. We'll communicate with the family. Like first we have during our first conversation, we'll tell that patient's condition is very serious, and we'll explain like if you're not doing it, if you're not done any investigation, you have to tell to them. Communication is very important, otherwise you'll get beaten up. They'll tell that we have taken the patient to hospital and from there nothing has been done. So that you have to tell them why we are not doing, why we are not investigating him, why we are not giving some other treatment, because we know that sometimes he may not be benefiting from that, and about the life expectancy of the patient. So all these things have to be communicated with the family, and we have to address both the patient and caregiver. We have to calm down them. Both of them are suffering. Hmm? So communication is very important. We'll tell about why we are not doing any investigation, and we'll tell about what is his current condition, and whether he is going to benefit with any investigation or any treatment, and why we are not doing this and why we are doing that. Everything should be told initially itself. Okay. And now, yeah, shift him to ICU, whether we have to shift him. So in this situation, I don't think the answer is yes. We have to consider the last wishes of the patient. A patient might be wishing to be with his family during his last days. But the decision should not be made by us. It should be made by the family. We should tell them. We should tell about all these things, different aspects about the patient's condition, about his patient's wish, his last days, his thoughts, his anxiety. It will be very difficult for him, like to be separated most of the time. What we see here, I'm telling about considering that, like when you separate the patient from their family members, their anxiety will increase. That we have discussed it earlier. The anxiety, dyspnea, viscous cycle. Hmm? That in turn increases their anxiety, and that in turn increases their breathlessness. So this has to be kept in your mind. Now, so about we communicated everything. We have told about all the investigations. We have told about every treatment, life expectancy. We are not shifting him to the ICU. And next what? These all three things: correct the correctable, non-pharmacological, and pharmacological. This is a management of breathlessness. This is the correct management. So there is a myth that like everyone thinks that when it comes to palliative care, nothing can be done. We are not going to give any medicine. Is it like that? Never.
No, ma'am.
We have to correct. We have to, yes, we have to correct the correctable. If something is there, we can correct it. We have to do it. If we are not doing it, that is our negligence. So what are the correctable things? Sometimes a patient will be having a respiratory breathlessness due to a respiratory infection, and you're giving an antibacterial. His infection will be controlled. His breathlessness will reduce. If the patient is having a pleural effusion and you're telling that no, no, nothing can be done. Is it like that? No, it's wrong. You can do a pleural tapping for that patient if it helps. If it helps, if it relieves the symptom, you can do that. If the patient is having ascites and you're telling no, no, nothing can be done, he's having advanced disease. Is it right? No. You can do a paracentesis. That will relieve his breathlessness. If it is an anemia and it is causing breathlessness, you can correct by giving a blood transfusion. If it is a heart failure, can give diuretics. So do not forget to correct the correctables. Do not leave it like that. It's not like nothing can be done in palliative care means it's the end. It's not at all like that. We have to see. We have to, if the patient is not going to improve, then okay, fine. Now, coming to the non-pharmacological methods. These things are also very important. We will not be hearing about this before. So, like we discussed before, non-pharmacological, before giving the drugs, we have to do some things. Not like giving, well, now in a casualty patient, rush to hospital, like to the casualty with breathlessness, and you assess, we have checked the SpO2, it is very low. You give oxygen, you give Rexona, and it's not like that. You have to talk to the patient. We can try, we should correct the correctables. And then coming to the non-pharmacological methods, we have to do certain things. That is, first is the calm presence of a healthcare team conveying empathy. It will relieve the anxiety. That's what I said earlier, that we have to address the patient. We have to tell them, don't worry. It should not be like, you are going to be okay. We are going to give injections. It's not like that. We have to give, we have to uh, like what, we have to give a good empathy to the patient. We can tell like, I'm going to be with you, we are going to try injections, and we'll see whether it can relieve your this breathlessness. And one of the easiest thing, we what we usually practice here is, we'll tell like, one of us is going to be here. Could be doctor, could be sister, or anyone else, anyone from the healthcare team. We'll tell that we'll sit with you until you become a little okay. That itself will like relieve their anxiety. And how, in turn, the dyspnea anxiety cycle that will come down. The anxiety level will come down, and the patient will be little more anxious level will reduce. Next, what we do is we loosen the patient's cloth. They'll be having a feeling of tightness. When the patient is having a breathlessness, there will be chest tightness. So just release their clothes, loosen the clothes. And next thing what we do is use a table fan, and we have small handheld fan here. They'll give, sometimes we'll give that to the patients. For those who benefit with that, we'll ask them to continue use. We'll keep a small handheld fan in front of the face, and we'll give air. For some patients they will tell like there is no use, but for some it will be there will like increase perception of space and wind, that relieves the breathlessness. And what, keep rooms windows open, that increase the perception of space. Then is a very important thing, comfortable position of the patient. Like we discussed in the examination part, most of the people, they will not be able to lie down. Patients with breathlessness, they will not be able to lie down. But for some, it's not for everyone. If some patients are coming with breathlessness, you can keep them in semi-fowlers or propped up position. You can make them into a like in a propped up position. That will, uh, if the position is comfortable then for them, you can continue like that. Then modified breathing techniques like pursed lip breathing and diaphragmatic breathing. You can advise all these things to them. So before going into drugs, you can try all these things. This is a not definite solution for the breathlessness, but all these things are supportive. Okay, all this anxiety, dyspnea cycle, and the calm presence of healthcare team, all these things will support the pharmacological methods. Okay, now we are going to start our medicine, and the patient will try giving bronchodilators. So patients with bronchoconstriction, sometimes the patients with bronchoconstriction will improve. And next thing is a corticosteroid. How will a corticosteroid help here? Corticosteroids in cancer it is very helpful, because not only in lung malignancy, in other cancers also, most of the tumors will be surrounded by a peritumor edema. There will be a tumor, and around that tumor, there will be edema. So what happens? When you give a corticosteroid, this corticosteroids reduces the level of peritumor edema. So in turn, the size of the tumor will be reduced. So the tumor pushing all the walls, the tumor compressing all the vessels, all that will come down. the patient will be feeling little more better. We use regularly here. Corticosteroids is very helpful. So first we try with bronchodilators, then we give corticosteroids. So in the patients with lung cancers or lung malignancy, lung tumors, what happens is the tumor size will reduce. When the tumor size reduces a little bit, when the peritumor edema reduces, there will be at least a small increase in the diameter of the alveoli. We know that even a small increase in the diameter of the alveoli brings a great relief for the patient. A patient having hypoxia, and if you're giving simply an oxygen, it will not help them. But if the corticosteroid can reduce the edema, and if the bronchodilation occurs a little bit, he'll get little more oxygen. That will help him. So we can give corticosteroids. And seeing that patient, we have given everything, usual, everything we have given. We have given nebulization, we have given corticosteroid, and even after that, patient is not improving. And here comes our wonder drug, morphine. You will be thinking, hey, how come morphine? Morphine is an analgesic. We use it for pain management, and how it comes here in under respiratory system? Yes, morphine has one more use. It is used in respiratory symptoms. It's used for breathlessness. It's a wonder drug. It's very helpful. So where do we use this morphine? It's not like a patient having a cough, or simply a breathlessness. We can give morphine like that. It's not like that. When the patient is having intractable dyspnea, not responding to any other treatment, we can give morphine. How will it help? You know how is the mechanism of action? How morphine helps? It decreases the respiratory drive. It reduces the respiratory drive, and the breathing is more efficient, and the sensation of breathlessness is reduced. That's how it works. Not like in anything. This is the mechanism of action. Morphine, listen carefully. This is how morphine works in reducing breathlessness. Morphine helps in reducing the sensation of breathlessness, and it reduces the excessive respiratory drive. Okay, that's how morphine works. Morphine is helpful in pain management as an opioid. It is helpful in controlling the respiratory symptoms. So, what is the dose? Is it same like we do in pain management? No, we don't need that much dose here. We need only very small dose. As we know, in pain management, usually we start with 5 mg morphine. Is it not? We'll start with Q4H. But here what we do is we give very low doses. It is 2.5 milligrams to 5 milligrams. Sometimes we'll start with 2.5 milligrams TID or 2.5 milligrams Q6 And if the patient is having breathlessness, the patient is responding, we can increase the dose up to 5. We can increase the dose, not up to 5, we can increase the dose. But always the starting dose, most of the time it will be very low dose. It is 2.5 milligrams. Okay. So here in this slide, what this slide have to be kept in your mind, how morphine work and how does it act, what is the dose to be given in a patient with breathlessness. Okay. Now we have given morphine and we have given corticosteroid, we have given all the nebulization and all. Respiratory drive has again reduced. And even after talking with the patient, we try to calm them down. And if the patient is not calming down, we can give a benzodiazepine. That will relieve their anxiety. That is also going to help. So in a usual setting, in a normal hospital, you will not be seeing all these things. Is it? So you have to be very clear why we use it, when we use it, and how we use it. Okay. So for benzodiazepines, mostly we'll be giving midazolam injections. Injection midazolam, it is short acting. We can give it, or long acting benzodiazepines like lorazepam. Okay. They are not first line agents. So don't go and tell that it was taught in a respiratory class. If you have breathlessness, go and give benzodiazepines like midazolam. It is not like that. It is just to relieve the anxiety. It's just a support. It's just a support to our respiratory management. Okay. Because what we know that anxiety increases breathlessness. Now, this is very important. Will oxygen help? This is very, very, very important. Like you said before, a patient comes to your OP with severe breathlessness, and Jakriti told that we'll give oxygen, right? So there is a little difference here also. Before giving oxygen, we have to think, will it benefit? Will it benefit? Most of the time, it will be a no. But it is very difficult for us to convince the family also. You have to tell them, Ma, Pa, this is not going to, sometimes this might not help. It will only cause a obstruction or it may increase the difficulty for, like, it will cause distress to them. How? When we are keeping a mask, patient is already very weak. He's unable to speak. His loudness of voice is very low. And you are going to fit a big mask to their face. And that is not helping his disease also. It will be a difficulty for them, right? And all these dry gases, and you are giving oxygen and you are giving a dry gas, and it will dry up the tract, respiratory tract, and that causes that increases the distress. Now, a face mask can cause, sometimes for some patients, it will be causing a sense of suffocation to the patient. So what we do is, we can give a cannula, nasal cannula, we can try that. But the thing is, we have to communicate with the family. We can tell them that, yes, we have to explain this, that sometimes oxygen will not be helping them. And we can tell that we can give an oxygen trial for 10 minutes. It will not take so much time to see the improvement. Might be 7 minutes or 6 minutes. We give oxygen and we can see the patient is the blood oxygen equilibrium will take only 7 minutes. So within 6 to 7 minutes, we can understand whether the patient is improving. So we can give oxygen for some time, for 10 minutes. If the patient is improving, or if the patient is benefiting, or he is having a relief when you give oxygen, we can continue. Otherwise, please stop it. But this is very controversial because this is very difficult to implement. It's very difficult to implement here also. So we have to communicate a lot with them. Most of the people will not be understanding. And if you are not properly communicating, you will get beaten up. A patient came with breathlessness and a doctor and the nurse has not given oxygen. Very bad hospital. They'll tell like that. So you have to clearly, in order to avoid that only, we are doing this. We give an oxygen trial. For everyone, we cannot deny also. No, oh no, for this patient, oxygen is not going to help. So what can we do? We can give an oxygen trial. We'll see if he's improving. If he's improving, we can continue. Otherwise, we have to communicate them with them. We have to explain about all these things. Things you should we'll be able to tell them about this only if you know. What are the problems with mask? It will cause a suffocation. It will dry up the tract. It will cause a barrier for the communication. All these things you should be keeping, you should be able to tell them. So don't forget it. So that's what we give in oxygen trial. We'll try for oxygen trial also. So that's about breathlessness. Now, cough is very similar to breathlessness, and I'll just quickly go through cough because everything is somewhat the same. So the prevalence usually in cancer and COPD, and most of the patients having cough, they'll be having a psychological impact. Continuous coughing, other people will tell, oh, he's having TB, he's having other disease. Coughing, when you cough, the saliva comes out, and people may isolate you. The patients will get isolated. So we have to, then this cough is also having a psychological impacts on the patients. So causes of cough is tumor. It is also very common when it causes to cause involvement of airways. Then cancer involvement causing pleura and pericardium irritation. All these can cause aspiration. And complication is continuous coughing can cause chest wall pain. It is very common here. Fracture of rib, urinary incontinence, sweating, exhaustion, disturbance of sleep, and all. Assessment is same. And here also it is the same. Now come to the management of cough in palliative care. What we do is sometimes chemotherapy and radiotherapy will help in reducing the cough. That the when you give a chemotherapy or radiotherapy with patients having tumor, the tumor size will reduce, and by that we can reduce the cough. And like we said before, correct the correctables. Like the patient is having any underlying infection, we can correct it. Now, using cup suppressants, but sometimes cup suppressants fails, and then comes here also we give morphine. It's very rare giving morphine to these patients, but we can give if the patient is having intractable cough, not responding to any other medicines, antitussives. We give morphine, same like breathlessness. We give in very small dose. And along with that, supportive measures like protussives and emulsions for soothing substance like glycerol. Thank you. Thank you so much. You can ask me your doubts.
Hope you have
I've
understood
understood
my
my
session.
session. Thank you.
If you have any doubts, you can type it in the chat box or you can unmute yourself.
Hope this was very new to you, right?
Right?
We have not seen anywhere saying oxygen, pulse oximeter.
Oximeter.
All
All
these things are different. Is it not?
Not. Hmm.
I think everybody has understood the session, though it was a very informative session and very well explained. Still, if you have any doubts, you can come up with your questions.
I'm so happy everyone understood everything.
Okay, so we come to the end of today's session. Thank you, ma'am, for joining, for giving such a wonderful presentation.